I am Dr. Ruchi, HOD Department of Emergency Medicine in Yashoda Hospital, Kushambi. Today we'll be talking about alcohol intoxication. So before starting with alcohol intoxication, we should be knowing how many types of alcohols are there. So the categories of alcohol are monohydroxy alcohols, which is the edible form, it is ethanol. The other non-edible forms are methanol and isopropanol. Dihydroxy alcohols, so they have two hydroxyl groups, so that's dihydroxy alcohol, it's like ethylene glycol, propylene glycol. Trihydroxy alcohols are propane derivative glycerols or glycerin. They are non-edible forms of alcohols, but they are the variety of alcohols which is available. So what do you mean by acute alcohol intoxication? So acute ethanol intoxication means when it exceeds the legal limit of intoxication, that is above 80 mg per deciliter, or odor threshold is 10 parts per million. So WHO has categorized the drinking patterns of alcohol as social drinking, binge drinking, harmful drinking pattern, hazardous drinking, and alcohol dependence. So these are the patterns which defines the legal limit as well as the alcohol intoxication. So social drinking means it refers to the drinking of about 2 drinks per day for men and 1 drink per day for women on different occasions, probably not regularly. Binge drinking is referred to consumption of alcohol more than 5 in men and more than 4 in women, and it is more early. Harmful drinking pattern means it results in the physical and psychological harm to the individual or the society. So that is harmful. Hazardous drinking pattern means the alcohol consumption is affecting your health adversely. That means it starts affecting your liver, your kidneys, your psychological behavior, you start getting seizures maybe. And alcohol dependence is severe behavioral, cognitive, psychological phenomena. So that you become dependent on alcohol, and in the absence of alcohol your body tries to react and you get alcohol withdrawal symptoms. So that is alcohol dependence. So the absorption of alcohol is around 70% from stomach, 25% from duodenum, and very small amount from mouth and esophagus. Pathophysiology of working of alcohol is it affects your nervous system. It stimulates GABA receptor, increase NA-NAD ratio. It increases ketogenesis in liver and decreases gluconeogenesis, and it increases glycogenolysis. So in this causes the decrease in weight, your ketogenesis. This is the pathophysiology for it, and it causes severe fluid and electrolyte imbalances. So usual fat. So when we have taught the normal limit is 80 mg per deciliter. Now the one pint it is 550 ml. So strong distilled spirit such as whiskey in short span can be lethal. So if we take this much of alcohol, it will be a fatal dose, overdose of, or what we call as acute alcohol toxicity. If we take this much of amount of this 550 ml of amount of whiskey, the usual fatal dose corresponds to approximately 6 grams of ethanol per kg body weight in adult and 3 grams per kg body weight in children. In terms of blood alcohol, a level in, so BAC is blood alcohol concentration is another thing which we see or which is a marker with which we can define that if we are having alcohol overdose. A level in excess of 400 to 500 mg per 100 ml is usually considered to be lethal. However, there is a great deal of controversy regarding this, since there are case reports of individuals succumbing to much lower blood alcohol levels concentrations, while there have been reports of survival even with blood BAC of over 1000. So it will depend on person to person. So this is a pathway of ethanol metabolism pathway. So in the first one we can see ethanol is converted to acetaldehyde and NADH is produced, and then it is converted to acetate, for which we need a radical of NAD. What is acute toxicity is when we get the metabolites like H2O2, and we get lactic acidosis, ketogenesis, and increase in triglyceride formation, ROS and muscle weakness, flushing, nausea, headache, and general discomfort. So basically, the free radicals they are produced, and this causes acute alcohol toxicity. Chronic toxicity it affects your different organs, like in liver toxicity. The you can see the increase in metabolism, acetaldehyde formation will be there. There will be the hepatic cirrhosis. So this is the pathway for chronic toxicity of alcohol. So we have observed in alcohol, thiamine is has a very important role because alcohol causes thiamine deficiency in brain by impairing thiamine transporters by blood brain barriers or gut barriers. Alcohol decreases synthesis of TPP in brain cofactors, activates. So this is thiamine pyrophosphate. So basically it increases in brain. Decreased synthesis of TPP in brain leads to Wernicke-Korsakoff neuropathy. So this is a pathway which leads to this, and for this we have to give thiamine to a patient of alcohol intoxication. So again, as per the mg per percentage or the concentration of alcohol in blood, we can see the pathway, how it goes in your blood and how it affects your system. Stage of excitement, stage of incoordination, and stage of narcosis. It can depend from person to person, but usually it is seen that within a concentration of 30 to 100 mg percentage, there is a stage of excitement which is very common. We see excessive talkativeness, increased self confidence, decreased sensory perception, loss of fine motor skills, slowed information processing, and increased sexual desires. Stage of incoordination is from 100 to 300 mg percentage, and it is incoordination of thought. You don't know what are you speaking, impaired judgment, you are not able to decide, confused, slurred speech, and there is a staggering gait. Nausea, vomiting can be seen, pupils can be dilated, and this is the stage where you see the most of the criminal offenses. In the concentration of more than 300 mg percentage, there is a stage of narcosis. So in this is a toxic stage or severe alcohol intoxication, where it starts affecting your adversely affecting your organs. There will be deep sleep, rapid pulse, hypothermia, labored breathing, contracted pupils, and coma, and death can be seen. Associated acute problems. This is all of us are very well versed with it. Alcoholic ketoacidosis, alcoholic hypoglycemia, fluid and electrolyte imbalance, Wernicke's encephalopathy. We have already talked about it. Acute effects on heart, acute GI effects, acute alcoholic myopathy, trauma, associated other substance poisoning. Henry's law. It is the ratio between concentration of alcohol in alveolar air and the blood is constant. So, what is Henry's law? It says कि it depends on your concentration of alcohol, how much alveolar air or blood. The concentration of your ethanol will depend your exhalation of alcohol and in the concentration in blood. So this is what the alcohol breath test depends on. This alveolar air blood constant ratio 1 is to 2100 forms the basis of reliability of estimating blood alcohol concentration by breath analysis. So this is how we get it. Clearance 15 to 18 mg per 100 ml of blood per hour. It follows zero order kinetics, and it is independent of alcohol concentration. 2 to 10% is excreted directly through lungs, urine, or sweat. But the greater part, that is 90 to 95%, is metabolized to acetaldehyde primarily in liver. Blood levels of ethanol are expressed in milligrams or grams of ethanol per deciliter. Values of 0.02 gram per deciliter resulting from ingestion of one typical drink. So this is how the alcohol is cleared from our body. So this is the rate which we can see. The coverage rate of ethanol metabolism is 100 to 125 mg per kg per hour in occasional drinkers, and it can increase up to 175 mg. So basically the habitual Drinkers, they excrete it early as compared to the occasional drinkers. This is what this slide means. So this is the pharmacological effects of alcohol in different systems, which we have already discussed, but we'll go through. In genitourinary, alcohol is an aphrodisiac, so it induces diuresis by inhibition of ADH. Chronic ethanol consumption can lead to impotence, sterility, testicular atrophy, and gynecomastia. So these are the chronic effects which we see. Ethanol normally stimulates salivary and gastric secretion, but if concentration is too high, they are inhibited. So in a higher concentration, it will be the other way around. And the GI mucosa becomes congested and inflamed, leading to erosive gastritis. I'm sorry. Regular intake of excessive amount of alcohol leads to chronic gastritis, pancreatitis, and cirrhosis of liver, which we all know. Tachycardia and vasodilation of cutaneous vessels results in the warm and flushed skin. That is why we feel hot. No beneficial increase in coronary blood flow occurs. In fact, there may be appreciable vasoconstriction, which can aggravate existing angina. Recent studies have indicated that regular use of moderate amount of ethanol is associated with reduced risk of CL. So this data is quite controversial. We don't know, but yes, of course, alcohol is indicated in a lesser amount regularly, which might prove cardioprotective if we take it in a moderate amounts. CNS, it has inhibitory control mechanism in brain. Person become expansive and may demonstrate emotional liability with mood swings, sensory and motor disturbances, general impairments of CNS function, and finally coma supervenes. So alcohol from acetaldehyde, acetate increase NADH, NAD ratio, decrease gluconeogenesis. This we have already discussed. Ketogenesis, glucagon, and increased glucagon and decreased insulin. Acute ethanol poisoning. So with this we have already discussed the stage of excitement, stage of confusion, coma, and death. Chronic poisoning. So in GIT, chronic poisoning can lead to periodic dry diarrhea. So sometimes the people come with the complaint of chronic gastritis, periodic diarrhea. So the history of chronic ethanol intake is very important. In liver, hepatitis, cirrhosis, increased incidence of hepatic carcinoma, pancreas, acute or chronic pancreatitis or pancreatic cancer, pancreatitis or pancreatic cancer, CNS polyneuropathy, cerebellar degeneration, demyelination of corpus callosum, in respiratory asthma. So these are the very chronic. These are very chronic kind of things. So this happens if the patient is a chronic abuser of alcohol. So there are different lab investigations which we should do. That's the blood alcohol concentration, which we can do till 24 hours. So the alcohol concentration alcohol can remain in our blood for around 24 hours. So blood alcohol concentration test is readily available. We can do that. Serum osmolality, it increases. The sodium, potassium, calcium, these levels can vary depending on the type. So if we have diuresis, the sodium level might decrease. If we have ketogenesis, the potassium might increase. If we have recurrent vomiting, so we can have the patient can have hypokalemia as well. Blood urea nitrogen, of course, the acute alcohol intoxication causes severe acidosis, so the blood urea nitrogen might increase because of the dehydration. Blood sugar will decrease because of decreased gluconeogenesis. Amylase lipase will increase in chronic toxicity of alcohol. LFT will be deranged. ABG will show acidosis, so it will be the metabolic acidosis, which we will see in our ABGs. Blood ketone level in acute toxication will increase. ECG may show arrhythmia leading because of the hypokalemia or because of the tachycardia. Chest X-ray, if the patient has chest X-ray can be normal, or it might show aspiration pneumonia if the patient have recurrent vomitings, or patient might have aspirated in a comatose state. CT head when head trauma is suspected. So alcohol, any patient of alcohol abuse coming in unconscious state, a CT is must if the history of trauma is present, because we don't know the impact of injury because of the effect of alcohol might be even much more than what we see. And there is one more thing, that if a patient comes with alcohol intoxication, we should look for other type of toxicities as well, because most of the time alcohol is not consumed alone. It might be abused with other drugs like cocaine or so. So usually we send a panel of toxins, urine tox, so that we can get other type of toxins as well. So the urine tox can also be sent in alcohol intoxication. So, as an emergency physician, whenever we talk about any kind of intoxication, any type of poisonings, alcohol intoxications, we should always start with ABC. How is the airway? If the patient is talking, if the patient is not able to talk, if the patient is unconscious, if the patient is vomiting, so that's the way we do airway assessment. The patient is talking, the airway is good, but if the patient is not, or the comatose, we should always look for the airway. We should always secure the airway. If we think the patient is not able to secure the airway, we can intubate. Breathing, we can assess the ventilation by giving oxygenation, by giving the airway intubation and ventilator support. Circulation, patient might be severe hypotensive because of the recurrent vomitings, acute electrolyte imbalances, acute dehydration. So good IVSS and good IV fluids along with thiamine. Thiamine is very important. Along with thiamine should be given to a patient of alcohol intoxication. We should be giving good amount of fluids. So Ryle's tube might help in some conditions if the airway is okay, but the patient might vomit. So we can put Ryle's tube with continuous aspiration so that we can deload the abdomen and the chances of aspiration is reduced. Propped up position to avoid aspiration and secure the airway is must. Foley's catheterization, of course, and mechanical ventilation if required. So how do we give IV? So this is the elaborated form in IV. IV solution containing at least 1 liter of half of dextrose nor normal saline should be given. 2 mg of magnesium sulfate will be helpful in cases of arrhythmias, and 1 mg of folate and thiamine will support and give will prevent vernix encephalopathy. Antiemetic drugs are must, so they are in the bucket list. Sedatives, if the patient is agitated or in a violent state, but while giving sedatives, we should be looking for the protection of airway. That is must. If we have to give sedation to an alcohol intoxicated patient, we might need to intubate the patient at the same time. So we should be ready with that. Haloperidol or droperidol, if the patient is severely hyperthermic, so we might use it, and to calm down the patient, haloperidol might be helpful. Physical restraints should only be used in extreme condition. Physical restraints can be dangerous sometimes because the patient of acute alcohol intoxication is so violent that he has to be chemically restrained. So if we want to restrain the patient with physical restraints, there might be chances that the patient might hurt himself, and mechanical ventilation and intensive care is must. Metadoxin is one drug and which is actually controversial, and it is used for treatment of acute alcohol intoxication. It is supposed to facilitate ATP synthesis and increase in ATP in both brain as well as in liver. A single IV injection of 900 mg significantly decreases the half-life of ethanol. So basically, it increases the metabolism of alcohol, and it helps to clear out from the blood. Now we come to methanol poisoning. Methanol is one of the dangerous alcohols available. Methanol poisoning it is colorless liquid, volatile liquid, and it is similar to ethyl alcohol. It is very cheap, so people try to mix it with ethyl alcohol, and hence the cases of methanol poisoning are also seen. It is very burning in taste, and it can be seen in homemade beverages, in antifreeze, paint removers, dyes, resins, and adhesives. So most of the absorption, as we have already discussed, is from 70% is from stomach, intestine is rest, and alcohol and lungs and skin. Fatal dose is 60 to 200 ml. Even a smaller dose is very dangerous for the people. The fatal period is 24 to 36 hours. And of course, as we know, the cause of death is mostly acidosis. It causes severe acidosis in blood. Signs and symptoms will appear within an hour. In GI, we will see patient will be having severe nausea, vomiting, and abdominal cramps. The CNS symptoms are more intense and persistent than with ethanol. Severe headache, dizziness, delirium, neck stiffness, confusion, vertigo will be there. Patient may be comatose. There will be blurry vision, eyes, and the retinopathies are very common. Patient will be tachypneic, tachycardic, hypertensive, and hypothermic. In liver and kidney, there will be acute tubular necrosis or the toxicity. Severe non-diabetic anion metabolic acidosis is very common. Visual disturbances, as I told, photophobia, blurry vision or misty vision, central or peripheral scotomas, floaters, decreased lifespan. So basically, methanol affects your retina, and it is very dangerous to eye. You can be permanently blind, and so methanol is very dangerous for eyes. The fundoscopy shows hyperemia of optic dust followed by retinal edema. So to protect your eyes, so the vital organ of your body, you have to keep the patient in dark room to protect the eyes from sunlight. Maintain airway. Again, airway breathing and circulation is the key for alcohol intoxication. The supportive management is must. Place the patient in left lateral decubitus or the propped up position to avoid aspiration. Gastric lavage is indicated in these cases with 5% bicarbonate can be used in gastric lavage. It will help in decreasing the acidosis as well as the rapid removal of methanol. Activated charcoal to reduce absorption of alcohol. So administration of ethanol as a competitive antagonist. Loading dose. So we are not that happy giving IV 10% of ethanol. So usually the usual dose is 0.8 to 1 ml per kg orally. So we will give it via RT ethanol in 200 ml of fruit juice. So we will not give just ethanol. We will mix it with fruit juice and try to give it with RT so that it will act as a competitive antagonist, and it will the ethanol will bind to the receptors and methanol will be secreted. Maintenance dose is 1.4 ml per kg per hour in IV and 0.15 ml per kg per hour orally. Desired serum alcohol concentration or the blood alcohol concentration is 100 to 150 mg per kg. Fomepizole is a good drug which can be used in acute methanol toxicity. The loading dose is 15 mg per kg over 30 minutes, followed by 10 mg per kg every 12 hours for 4 doses, then 15 mg per kg every 12 hours. Continued hemodialysis, treatment of choice in severe cases. So it is a lifesaver. Patient will have to be put on hemodialysis as early as possible because methanol is a very toxic drug. Folic acid 50 to 70 mg every 4 hours. Blood sugar is measured frequently while ethanol is given because it can cause severe hypoglycemia, so we have to keep it in mind. Basic treatment for alcoholic ketoacidosis: crystalloid therapy, dextrose, thiamine, and phosphate. Correct potassium and magnesium. Sodium bicarbonate IV should be given. So basically it is a treatment of severe metabolic acidosis which we had, it is treated on the lines of DK, diabetic ketoacidosis. So there will be huge anion gap in ABG. If you see, there will the anion gap will be very large. There will be severe metabolic acidosis. Patient has to be given a lot of fluids. It should be given ethanol, sodium bicarbonate. Patient has to be intubated, put on ventilator support if required to protect the airway, and hemodialysis should be done to remove methanol as soon as possible. Thank you. Thanks a lot.